with no complaints?
We can do it. I mean, it's just for general discussion about what we use.
100.
So this was as you can see, 100-year-old, has a POA, history of dementia, agitation combativeness, and the main point here is that the son, the POA, is requesting transport, but the patient is not cooperative with that, and the crew could have, now remember there's two kinds of POA, right? What are the two kinds of, oh, there's good ones and bad ones, I suppose, but what other?
You're talking about like medical in general?
Yeah, medical, and I think I don't know what the official terms are, but I think of them as medical and financial. So you can absolutely have a POA who handles your financial matters, but you still take care of your own medical issues. And then if it's a medical POA, the medical POA only takes effect when?
The person is incapacitated or unable to make their own decisions.
Correct.
Which
So
you
it
could
doesn't
argue with
mean that just
dementia.
because you have a POA, I mean, everybody should probably have a POA, just like you should have, you know, your advanced directives. You should have somebody that you've designated to make decisions for you that you trust when you can't. But that doesn't mean that you can't make your own decisions. And I mean, a 100-year-old doesn't necessarily, just by definition. And the other thing is, just because you have a history of dementia doesn't mean people don't make their own decisions. Dementia obviously is on an incredible spectrum. I find that family members and the POA often assume that they get to make every decision. So you have to kind of tease that out a little bit. It's just like we say also for parents. Parents are allowed to make good decisions for their children. I mean, if the person is calling themselves a POA, whether they have paperwork or not, I mean, if collectively it just seems like the right thing to happen, it's less of an issue than if everybody is at odds. Then it becomes a little more, if you're being asked to do something that the patient isn't really comfortable with and you're not really comfortable with, then it becomes that much more important to be very clear, is this a medical POA, and is this in effect, does this person make their own decisions? Sometimes it can be hard to figure out, you know, it's not always easy. So I think the point here is that in this case, the patient was refusing and the crew wasn't comfortable in and of itself with that, which is fine, and then they reached out to the consortium for help and also some additional documentation since our calls are all recorded. If we thought that this was appropriate, if everybody was, I mean, I would just a reminder, you don't have to call the consortium for a forced transport if you think the patient needs to go and the POA, who you really think is the POA, just based, I mean, you don't always have to have paperwork, just your best judgment is that they are the POA. You know, if somebody's lying to you, that's possible, but, and you think they're acting in the patient's best interest, then you don't have to call. You could force transport in and of itself. If you're not sure, then that's totally appropriate to make a phone call, and it sounds like there was an agreement to, you know, to have this patient transported. I think this was a nice little statement that was made here. Agreed, the patient met forced criteria due to her being altered by her dementia, safety risk to herself and to her son. You know, that's great. Be careful of putting too much documentation of what the doc said, because you don't want to. They're going to have their own documentation on the call, so you don't want to say one thing and then have the recording say something completely different. But I think that's just a nice little summary statement, and we took the patient. So just a reminder about POAs and a reminder, you know, consortium as a resource. This is a standard situation we deal with a lot of these. Yeah.
I have a question, kind of in regards to something like that. What happens when it's a facility that's calling you to transport a dementia patient, and they're saying the doc wants her out of here, but the doc isn't even on scene or in the same state sometimes?
Oh yeah, no, we get those all the time.
And the patient's refusing,
Right.
has no general complaint to go, but the doc wants her out because it's calling in a statement saying that the dementia patient is combative with staff, and that's why they want her sent out.
How many people have had this scenario? Right? This is too common. Now, sometimes the facility, I'm going to assume that the facility is well intended and that somebody had a concern, they called the provider, and the provider was like, oh, just get him to the hospital, thinking that this patient really does need an adjustment of medicines or needs to have a workup to see if there's a medical thing that's exacerbating their dementia. So I'm working from an assumption that, that everybody's, has good faith. However, it's the same thing applies. The facility can't tell us to abduct a patient, right? Just because a patient is in a facility doesn't mean they don't make decisions for themselves. Sometimes it can be really hard to tease that out. Sometimes, right, you have to try to actually make a call to hey, well, I'm gonna need to talk to this provider, just kind of explain to them. It's just like, hey, I understand but here's what I'm seeing right now. Right now, what I'm seeing is a patient who is able to make decisions for themselves and doesn't want to go. What are you hearing? And just try to make it as collegial a conversation as possible. And then you can also, obviously, if the POA or the family, you can try to talk to them directly. And then that is a classic consortium phone call. We get that call, unfortunately, all the time. The consortium, we take about 300 phone calls a month, and I bet you, I could pull the data, but I'll bet you 25 of those calls fit that description. And when we take the call and we have the discussion, more often than not all the time, but more often than not, we leave the patient there. And sometimes I'll try to get on the phone. Hey, do you want me to? So it's not on you. Do you want me to talk to the nurse and just kind of explain? And yeah, but just because it's a facility, the rules don't change.
Okay.
What else? And speaking of facilities, Captain Ray just brought up, I guess, a very recent situation. I don't know if any of you were involved. He said it was like in the last week.
Yeah, Chief, if you have a little bit of backstory on 4210.
Yeah, so they went to 4210, and when the medic on scene, Brandon Cook, he called for MedCom and PD to go en route. There was a combative patient, and to my understanding, when they got there, the conclusion they came to was to sedate the patient. So they sedated the patient and then transported. And then we had the same call the next day with a different patient at the same location. And MedCom went back out there and said, we cannot continue just to sedate the patients when they're combative. We need to come out with another solution when something like that happens.
So, was there, what we were hearing was that maybe the facility wanted us to sedate the patient
Yes.
but not transport at that
Well,
time?
they wanted to sedate the patient with their drugs that we don't carry and then transport him. And we said we can't do that. And then they wanted us just to sedate him with our drugs and then keep him there. And then, so it was a little.
So Juanita was on the call. She was
That's what I love about this job is after all these years, they can still come up with something new.
And then they were like, can you hold them down when we sedate him with our drug and then we'll keep them? And we were like, that's just weird.
Yeah, that is weird. The one part of that I can say for sure is that, we're not in the business of sedating and leaving patients, right? So that's not an option. Outside of the weird scenario of you get there, the patient, in your mind meets criteria to transport, in your mind is going to require sedation in order to facilitate that transport for their well-being. You start that process, you sedate, and then a POA, who's a legit POA, shows up and it's like, look, this patient is DNR and I don't want them transported. Okay, that's going to be a consortium phone call and we're going to have to sort that out. And I could imagine that we would potentially leave a patient, but that's not, if something happens to that patient as a complication of the sedation, it's really on us. So you are giving 100% faith in that facility to manage any complication of the sedation, right? So that's just not a thing. So if the patient does need sedation for an appropriate transport, we do that all the time. As far as helping to restrain a patient for their sedation, wow, I don't even have an answer for that one. That is a new one for me. I'm just gonna, that's a use your best judgment. I mean, I could see where that may seem appropriate, and I could also see where that, I don't know, that's a tough one. Chief, do you have a thought on that piece of it? What would you tell your crews if they called you on that?
Well, you know, I called them because they called for PD and MedCom, so I called the captains, you need me out there, right? And they said, no, we got taken care of. So I do believe that they do have the best judgment, and, you know, my medics are very conscious of liability. I think, like you said, if we're going to sedate the patient, then we transport, because I'm not going to leave 100% faith that the facility's going to take care of them. So.
Yeah, it sounds like we all agree on that. I guess, I mean, from my side, I wouldn't say that it's, I can't tell you that there's anything that says you can't help assist them. You know, we administer other home medications, I suppose you could imagine. And what if this were, you could take all different variations. What if this were a kid who had a fever, and you have a new parent who has no idea how to give ibuprofen to a kid, and you just need to help them hold the kid while they give ibuprofen, right? I mean, so I can't say that that can't be done, but we just have to make sure that we are not giving our meds and leaving the patient there, outside of a consortium contact for some weird circumstance. That's a good one. Leave it to 4210. All right, what else is on our, so while you're pulling up charts, TXA, I know was a question, what I heard was the question, was TXA use for indications other than trauma? So TXA is now paramedic scope of practice, so it's no longer a special skill for over, is it 16? Age 14? I think it's 16. So certainly for adults, I can't remember where the scope made the cutoff, but it's scope of practice now, it's no longer special skill. Doesn't specify, so now that it's in scope, it doesn't specify the specific indication. So it just says TXA. TXA, we want it to work for lots of things that it doesn't work for. One of them seems to be GI bleed. The evidence for GI bleed, there's a bunch of studies for GI bleeding and TXA, and the balance of the evidence says doesn't help, and there's a potential for harm. So right now, unless there's a new study that comes out and shows us the right dose in the right circumstance, no TXA for GI bleeding. Then the other one is postpartum hemorrhage. Where are we at with adding oxytocin back? Is it on? Yes. It's already on?
Yes.
Okay. So there is a renewed focus on postpartum hemorrhage. And this is both a BLS topic and an ALS topic. So it's interesting that like this topic of postpartum hemorrhage just sort of went away for a long time, and women didn't stop having babies, and women didn't stop having complications. Nothing really changed in the statistics, but there was a new focus on, oh yeah, you want to take this down so I'm not all distracted by it. So it is still postpartum hemorrhage, 2024, rich country, women still have significant morbidity and women die from postpartum hemorrhage. Crazy. So one of the things, so what is our, you have a woman who has just, so we've completed stage 2, she's delivered the baby. Okay. Chances are, you know, probably not staying on scene for a long time after that, although it is, depending on the circumstance and the situation, that shouldn't be an emergency. Childbirth is, you know, 99.9% of the time is the most natural and uncomplicated process, and so it's totally appropriate to wait on scene for the 3rd stage and placental delivery, case by case, depending on the circumstance, right? If at that point, though, you're starting to see a lot of bleeding, more than you would expect or want to see, what do we do?
you can do the fundal massage.
So the absolute first treatment for that, besides encouraging delivery of the placenta, and when I say encouraging delivery of the placenta, you can absolutely apply some gentle traction on the cord and help that deliver. You're not gonna but that will actually, because what controls most of the postpartum hemorrhage is the contracting of the uterus. And the uterus cannot completely contract if the placenta is there. So, and sometimes you're just kind of fooled by the bleeding that's just part of the third stage, and so when you deliver the placenta, things just improve anyway. So you can encourage gentle traction on the umbilical cord, and you want to do fundal massage. Fundal massage, what does that look like? We'll see that again. Yeah, it is not a gentle, benign, massage is not the right word, right? This has to be very vigorous. And the more bleeding it is, the more vigorous it gets. And it really is supposed to be it is a fist into, the area of the fundus. And ideally, there's a gloved hand on the inside and you're actually doing some, contraction in between. Most of you aren't gonna feel comfortable with that, so all the more reason you're gonna have to put more pressure on the outside to get that uterus to contract down. Delivering the placenta is absolutely gonna help. So that is a BLS move that fixes most of this. The next step is what?
Oxytocin.
Then it's medication, and it's oxytocin, which is also, you can also stimulate oxytocin. How else can you, at the BLS level, at the layperson level, how else can you stimulate oxytocin?
Feeding.
Yeah. So if the infant is vigorous, then you could have the infant nurse, and that will also stimulate oxytocin release. If this is a resuscitation situation for mom or for baby, then that's not appropriate. But there's simple ways. We give oxytocin, it's super safe, it's super cheap. It went away for the longest time. When I was a medic, we carried it, everybody carried it, you gave it to every delivery, but then it went away from kind of routine for every delivery, it just went away for postpartum hemorrhage, and then nobody ever gave it, and it just sat on the trucks forever. That was our issue here for years, is that we had it and nobody ever gave it, and it's kind of a national people kind of forgot about it, on the hospital too, it went away, and now it's back as a routine. So if you're anybody who's been through OB rotations in the hospital recently, every woman automatically gets oxytocin after delivery. It's not just for postpartum hemorrhage, we just up the dose if there's a lot of hemorrhage. But for us, in the amount of time we're with a patient, it's just one standard to give. Then there's TXA is absolutely an appropriate medicine for massive postpartum hemorrhage. Chances are, in our system, by the time we get things going, we'll probably have other things that we're going to be dealing with first, and we'll probably be at the hospital if we're going to RUST, for example, before. But TXA is appropriate and is absolutely used in the hospital for this, because you think about our 3-hour window, right? I mean, if you're on scene for static delivery and postpartum, you're within that window. So that would be appropriate at the same doses. But GI bleed, no.
So you could do this concurrently, bundle massage,
If they are absolutely massive bleeding, then yes, you can do all of the above.
Is there any worries or negatives, or I guess contraindications, for say TXA 2 days postpartum?
Yeah, I mean, we tend to, it's not clearly defined, but we tend to use our 3-hour cutoff for, because the issue, why don't we give TXA past 3 hours for trauma?
Is their clotting agent just basically gone, non-existent?
Well, it's related to clotting, right? Because unlike, remember we just talked about thrombolytics, right? And the thrombolytics are trying to help the body break down clots. And so if the complication of that is break down too much clot and you bleed. TXA is the complete opposite. It's a pro-coagulant agent. It's pro-thrombosis. It's trying to help the body make clots. So the problem with the complication of that is too much clot or clot where you don't want it. And in the trauma patient, that could be in lots of places, but pregnant women are already predisposed to clotting, in particular DVT and PE. So that's the risk. That's why we don't routinely, unlike oxytocin, where it's a naturally occurring hormone, there hasn't been shown to be really any downside to giving it. TXA, we don't give it routinely to every woman because they're already at risk. We don't want to cause more risk. So I wouldn't be comfortable giving it outside of that, but if they're absolutely I feel like, and I've had that patient. I've absolutely had that patient where you feel like they're gonna die from postpartum hemorrhage. At Lifeguard, we've pulled, in the last 6 months, we've pulled 3 patients out of outside ORs in massive, I pulled one out of Socorro myself a few months ago that was, I mean, I got a picture of all of the blood products that patient got and everything. I mean, crazy how bad postpartum hemorrhage can be. We took her OR to OR, went straight to the OR at UNM for an emergency hysterectomy. So if it's that kind of bleed where they're because it can be just massive, in which case, yeah, throw everything. You're throwing fluids, you're throwing oxytocin, massive fundal massage, and TXA. But the thing is that not every bleed is because the fundus isn't clamped down. So that's why fundal massage doesn't fix all of these things, oxytocin doesn't. And there's other drugs that get used at the hospital.
So if they're hemorrhaging 3 days after birth, that's something different?
But yeah, that was most likely something different.
Oh.
I mean, and there's one of the, that makes me think about a retained product, or it's an infection and endometriosis that's presenting more as bleeding than.
Because we had a patient and she had a C-section and still had hemorrhage during the C-section. And then they fixed it, whatnot, she went home, and then 3 days later, we got called in because she was hemorrhaging again.
And that would make me think that was a surgical complication, that something happened from the surgery. Yeah, crazy stuff. All right, TXA. Any questions on TXA? All right,
So this next one is a gunshot victim rescue 2.
Oh, if it's in the last week and a half or 2, I was on vacation, so I am behind on my charts. All right. Okay, so I'm seeing this for the first time with you guys. So 47-year-old male, extensive cardiac history, stated to have had a pericardiocentesis in the last few weeks. What's a pericardiocentesis?
Draining of.
Okay, explain it for the BLS folks in the room.
It's basically draining of fluid around the heart.
So you had a fluid collection in the pericardial sac. Whether that fluid is fluid or whether that's blood, pericardiocentesis. So an esis is paracentesis is when we take fluid out of the belly. Thoracentesis is when we take fluid out of the chest. Pericardiocentesis is fluid from the pericardium. So that's certainly you don't hear that every day, right? Patient just had a pericardiocentesis. Family member stated downtime about 90 minutes. Okay, that's long. Chest compressions by PD, moved to allow work, airway established, size 6 ET tube. Tube was confirmed with capno of 12, which is a bit low on the capno, but at least we're confirming tube placement. Absent gastric sounds, clear lung sounds on the vent, CPR taken over, placed on the Lucas, line established, IO, showed to be PEA with no pulses, CPR continued. 1 round of epi, CPR every 2. 10 minutes after the initial epi, follow-up dose. H's and T's were addressed. So can somebody, for the BLS folks, somebody want to explain what H's and T's are?
So you're just trying to take kind of like a step back a little bit and take in all considerations as to what could have caused the cardiac arrest, like hypotension, tension pneumo, things like that. B-gel is another thing to consider. Maybe their sugar is low.
So H's and T's is a mnemonic to help us think of treatable causes of specifically PEA arrest. So H's and T's don't really apply to a patient who's asystole, and they don't apply to VFib, but it's a list of things like hypovolemia, right? Oh, we could give fluid. Hypoglycemia, you mentioned like tension pneumothorax. So it's a list of things that we think of. And it sounds like Captain Ray is going to put them on the board. So it's great. That's totally appropriate. H's and T's addressed. At this point, patient lost end-tidal CO2, quickly regained after pulling back on the tube, reassessed at roughly the 30-minute mark. No pulses, still in PEA, code was terminated. Total of 30 minutes of resuscitation, and so anybody have any thoughts? I don't think this one was put up because there was, like, somebody did something wrong. Any?
Yeah, with the 90-minute downtime, granted, like, I don't know what they saw whenever they walked in, anything like that, but is that something?
I mean, you can't ignore that. I mean, 90 minutes, I mean, also, right, we don't know. I'm assuming that
This was
90
my call,
okay.
so if I can answer if you'd like.
And I'm going to say what I'm going to assume that 90-minute downtime means, tell me if I'm wrong, is last seen 90 minutes ago.
Yes.
Okay.
Okay.
So, and I think that's probably worth clarifying, because I think the problem with downtime is it's a word that gets used in different ways. So, I think the thing that to me is interesting in this is this whole recent pericardiocentesis. So, if you have fluid that accumulates around the heart, we call that, it's a day of terminology, that is called what?
Cardiac. Well, could be.
Not yet necessarily. Just fluid around the heart is called what? So around is what's the
Cardiac tempo.
no? What's around? What's our term for around? Well, our Latin. We have to be Latin here, right?
Pericardial?
Hey, there you go. So pericardial effusion.
I
And
knew the
it's
second
worth-
part, I was testing you.
Okay. So it's worth noting that fluid around the heart in and of itself can be completely asymptomatic. So we all we say when there's fluid around the heart is it's a pericardial effusion. That fluid, if you have rheumatoid disease, if you have cancer, if you have congestive heart failure, those are reasons that you may develop fluid around the heart that's not blood. Or in the setting of trauma, in the setting maybe of having your trauma be from somebody putting a needle in, you can get blood around the heart. The pericardium is a very dense fibrous structure. But it will stretch if you give it time. So if the fluid, whatever that fluid is, slowly develops around the heart, you can have over a liter of blood in your pericardial sac and have almost basically no symptoms. I've absolutely had patients that, obviously they were in the ER, but they were there for weakness, maybe a little shortness of breath on exertion. You're doing your workup, and there's a few things like you get the X-ray and the heart heart looks kind of big, or there's some tip off, or you do your EKG and the electrical voltage is really small, or it alternates big and small, which means the heart's swinging. So somebody's like, hey, let's put an ultrasound on the chest. And you put an ultrasound, and there's just massive amount of fluid around the chest, around the heart. That's a pericardial effusion, but that's not pericardial tamponade. So what's the difference between pericardial effusion and pericardial tamponade?
Pressing on the heart.
Yeah, well, yes. What else? How?
Start being symptomatic, starts affecting your contractions.
I think it is now, when that effusion is now putting so much pressure on the heart that the heart can't function and you're now clinically symptomatic, it's really a clinical diagnosis of tamponade. There's also a way we can diagnose it on ultrasound, but it's not seeing fluid. You actually have to see that the low pressure right side of the heart, this is getting into details, is compressing when it can't keep up with that pressure on it. In trauma, and you just have a sudden, somebody stabs you in the chest, or maybe stabs you with a needle, you can get tamponade, they say from 20 or 30 cc's. Because it's a tight sac around the heart. It's gonna take days to weeks to months to stretch, and if you put 30 cc's in over 3 minutes, that can be enough to put pressure on the heart, and especially on the right side of the heart, because that's the low pressure part to begin with, that you can then have tamponade. Now you can also get tamponade over longer periods of time. It's just at a certain point, if there's more fluid than the pericardium can stretch to, and it puts pressure. What are the symptoms of tamponade?
It's gonna be low blood pressure.
Hypotension. What else?
Muffled heart tones.
So classically muffled heart tones, which, I mean, on the test it's muffled heart tones because there's supposed to be fluid around. Now, if you have a liter of fluid around the heart, you're probably gonna have muffled heart tones. If you have 30 cc's, you're not. Then again, if you're on a trauma scene, you're not gonna hear anything, right? And if you don't know what patients' normal hearts like, I don't even, if I'm trying to decide if somebody has tamponade, I don't even pull out my stethoscope. But on the test, right? What else do you see?
Electrical alternates?
Well, that comes from a big effusion, but that's not specific to tamponade. But that is a tip-off to make you think of an effusion.
Narrow DP ranges?
What's that?
Narrow DP ranges?
Yeah, narrow pulse pressure. Awesome. So narrow pulse pressures, hypotension. The patient, what else do you see? JVD. Because the right side of the heart is the vulnerable side. The right side is the first one to take the hit. Blood is going to back up. So JVD, hypotension, narrow pulse pressure, muffled heart tones. The ultimate is PEA cardiac arrest. That's the ultimate picture of tamponade. So I don't know, we'd have to get the postmortem from OMI. There's nothing we're gonna be able to do after, that long a period of time that would do anything different, so we just do everything we would normally do. If you had a PEA arrest with that story and you were like, I can see a hospital, that might be one of those times where I might be like, hey, we're gonna transport. And if you have somebody who can do ultrasound on scene and they see something, we don't train the medcoms specifically to look for that, but if you see something, if that's big enough, that might tip you off as well. But otherwise, there's nothing we do different. It just becomes interesting. Was there anything else on that one that you wanted to?
No, that was good, but you segued into something that I wanted to maybe have you speak about. So we've had some instances on the outlying stations to where there's BLS rescues, obviously, and they're under the impression or being told that they should wait on scene for either ALS to arrive or MedCom to arrive instead of transporting that patient. And, kind of going into when is it appropriate to transport versus when is it appropriate to remain on scene.
For just regular cardiac arrest,
Just-
medical cardiac arrest,
I
or
think
for
just
any patient?
in general, higher acuity patients, because it seems like the BLS crews are getting everything done that needs to be done, but they're remaining on scene for those ALS resources or medcoms or right on scene.
Yeah, that's I mean, what's your answer to that?
I think if those crews are getting everything done, you know, they're just delaying the inevitable of getting those patients to definitive care and getting those patients to ALS resources. There's nothing wrong with intercepting medcom or intercepting with your ALS rescue. Let's say you're out at station 6 and you need to intercept with either medcom or rescue 2. I mean, that's perfectly appropriate. Like if I'm coming from rescue 2, I just jump on rescue 6 and transport the patient that way. But I would much rather them start, if everything's done that needs to be done, and they're in the back of the rescue, I would much rather than have them start or initiate transport as opposed to remaining on scene for that extended period of time. And then that potentially puts whoever that ALS resource is further behind the curve if the patient tends to decompensate or issues come up. So I know that that's not an ideal place for us as an ALS resource to be in. It's rather shitty, but if you guys have the ability to initiate transport and everything's being done, then start that process.
And we've seen and we've reviewed quite a few BLS and ILS, I mean, not just cardiac arrest, but some other high acuity falls that have, I mean, crews are really stepping up, and the care has been excellent. And New Mexico gives the scope of practice, especially at the ILS level, but even at the BLS level in New Mexico, gives crews a fair amount of ability to treat some pretty sick patients. So I would agree. I'm just trying to think of what circumstances I would tell somebody, I mean, what that would be, and I think a lot of it is case by case, right? Is how far away is the resource? Is that resource, you probably have an ETA. Is it 3 minutes away or is it 20 minutes away? Yeah, but in general, I would agree with you. I would say to initiate, in most cases, initiate transport.
How about for, because we were just kind of having a side discussion, we had kind of a consensus, cardiac arrest, throw an AED on, or whatever. I mean, you one shock, you get pulses back, but you're all BLS. I would think I would stay for an ALS.
Yeah, I mean, cardiac arrest, we certainly, we've moved away from the scoop and run approach to cardiac arrest across the board. Both include, trauma arrest we can come back to, but we've moved away, but even mostly for trauma arrest and medical arrest and pediatric arrest. We shouldn't be, so the scoop and run days for codes are over. And we have lots, and even we know that the sicker the patient is, the more movement is destabilizing. And we don't know, I don't think we really know why movement is destabilizing, but we see it all the time. We see these really sick patients who are kind of peri-arrest, and we decide to, pick them up and get them out to the rescue. Sometimes for good reasons. You can't work in the house, it's an unsafe, crazy environment, but sure enough, just that movement is enough. Doing interfacility transport all the time, I try to explain to families and facilities, just so they're warned, we have a lot of patients who just decompensate with no changes just because of its seemingly movement. So in general, we don't want to cardiac arrest, we know the things that help, and we want to stay on scene and do those things that help. And we don't want to scoop and run with patients, especially after you get return of circulation, because they are so vulnerable in that period that in general, I would agree, code is a place that you would generally want to wait. The question then again is how long do you have, are we talking about waiting? And if you have a patient, so let's circle back to, let's ask the question, not even make this a BLS, ALS question. When do patients benefit from transport from a cardiac arrest perspective? Okay, so one, intra-arrest. So there's the patients that we're transporting with compressions, and then there's the patients with ROSC. Okay. So And I'm talking about initiating transport, right? There's the patients that have ROSCA then code again during transport, right? That we know. We're not talking about that. But in terms of initiating transport, at the time you're going to start, there's the patients that are getting compressions and the patients that have ROSCA. In terms of initiating transport with compressions, there's the patient that is an ECMO candidate, and there would be a very select subset of trauma patients. And it kind of falls into ECMO, but it would be hypothermia. It's about all I got for, I mean, we just don't, we want to, it's nothing magic that's going to happen at the hospital outside of those ECMO patients. So, and this includes pediatrics. So the days of being met at the curb by law enforcement, like handing off the football and throw them in the back and we start driving, which is how we ran pediatric codes as an EMS nationwide system for 30 years. Right? Now we know, and there's actually just a study that came out that validated that, which we've been doing in our metro area for a long time. Even pediatric codes, you stay and you run the code. Peds are almost never going to be an ECMO candidate, and if you don't get ROSC, we don't transport, which sucks, but we're doing the best thing for the kid. So, so it really doesn't matter to me, compressions, active CPR, whether you're BLS, ILS, or ALS. We don't initiate transport with active compressions unless they fall into one of those weird groups. And I think that we give more latitude, we understand for the BLS folks in particular, depending on the distance from the hospital and what you feel like, to move that patient. But in general, would you agree with that we would stay? So let's review the ECMO criteria for a second. Let's make sure we're on the same page about that. Let's use the board. How comfortable is everybody with I never know who's been to what presentations at this point in time. So is everybody generally on board with what ECMO is? I'm just going to assume that there's at least one person in the room, let's say, who's not. And just quickly, so ECMO is when we put a patient we basically put a patient, ECMO by itself, extracorporeal membrane oxygenation, is when we take patients' blood out of their body through a huge catheter, like chest tube size, circulate it through a machine, and put it back into the body. We can take blood out of a vein and put it back into a vein. And all we're doing is, that machine is just functioning as the lung for the patient. Takes CO2 out and puts oxygen in. COVID, great example. We did a ton of ECMO during COVID. We still do a bunch of ECMO for people who have really bad lung. We cannot oxygenate them with the ventilator and everything else. The ultimate answer is, well, we'll just let the machine oxygenate them. We can also use the machine to be the heart. So we can take blood out of a vein, send it through the machine to oxygenate it and remove CO2, and then put it back into an artery under enough pressure to get it all the way up to the brain. So now the machine is both the lungs and the heart. Okay, we happen to call that VA ECMO, veno-arterial. The other was VV, veno-veno. If you do that during cardiac arrest, some people call that ECMO. Some people call that, or most commonly you'll see the term ECPR, for extracorporeal or ECMO CPR. So we're using that machine. So most of the patients that are on ECMO in the hospital are not in cardiac arrest. We just had a patient recently who, on ECMO, that we just transported a lifeguard, who was not only awake and talking and walking and extubated and eating and drinking on ECMO. Their lungs were just completely trashed, and they needed to be taken somewhere to be evaluated for a lung transplant. But you get there for your ECMO transport, and the patient's like, "Hey, how you doing?" It's kind of a little freaky, right? So, not every patient who's on ECMO is intubated. Not every patient looks as sick as you think they would. So if we use ECMO for cardiac arrest, we call it eCPR. What are the criteria for putting somebody in general on ECMO, in which case these are the ones that we might consider transporting for ECMO?
I think it's hard to commit to memory, but they gotta be healthy.
Okay,
Kind of
so there's
relatively healthy.
there's in and there's out, right? The inclusion and exclusion, right? So both of you guys talked about out are major comorbidities because, I mean, ECMO is not what we call a destination. You're not like going on ECMO for the rest of your life. ECMO is to keep you alive while we can fix something. And patients who have end-stage renal disease, end-stage COPD, end-stage heart failure, active advanced cancer, I mean, those patients we just know from lots of experience aren't going to do well with ECMO. They're already really frail. This cardiac arrest is going to be probably the last straw, and we're not going to end up saving this patient. So major comorbidities, renal failure, heart failure, liver failure, all of these things, you're out. Okay?
30-minute transplant
Okay.
time.
So,
Oh, 3 minutes,
so that we have to get somebody, the current best evidence, and this is kind of like our talk this morning about, stroke. Best evidence is that the patient has to be on ECMO, and hypothermia is a separate category. Okay, I've flown all the way to Gallup and put somebody on ECMO who was, at the time we got there was like 3.5 hours into cardiac arrest. So hypothermia is out as a separate thing. But in general, they need to be on within 60 minutes from when they collapsed. So, in is less than 60 minutes. Now, clearly sooner, much like stroke, sooner is better. So 60 minutes from the time they collapsed, because we know that somebody collapses, and then somebody recognizes it, somebody calls 911, usually gets answered on the law enforcement side, depending on the dispatch center and how it's structured. Then it gets transferred to an EMS dispatcher, recognizes cardiac arrest. Hopefully, we've gotten much better in the system now about early dispatch before you have waiting for all the coding. But that whole process, just from the time they collapse to you getting tones, right? If that's 2 minutes, that's a world record. Then you have to get out the door and you have to get to the destination and find the patient, right? So if you can get out from the time you get tones, if you're at the patient's side in 10 minutes, that's pretty good. Now there's times when everything lines up and we get there in 4 minutes. But there's plenty of times in the county and other places, or you're coming out of district, might be 15 minutes. All those factors. Let's say it's 10. Let's say it's 2 minutes for the first part. It's 10 minutes for you to get to their bedside. It's already ticking. Now, this is not 60 minutes to arrive at the hospital. Because how long does it take to put somebody on ECPR? Well, it's a pretty complicated procedure. You're trying to, in the middle of cardiac arrest, with ultrasound, feed a needle, if I get a needle in their femoral artery and their femoral vein, and carefully feed in progressively bigger dilators and eventually put in a catheter that's the size of a garden hose. And often these patients are obese, and oh, by the way, there's CPR happening the whole time. So if you can do that in 15 minutes, that's pretty good. World record time has been described as 5 to 6 minutes, but it's also with patients obese and issues and you don't do it as often, I've also seen it take 20 to 30 minutes. So you now have to get the patient to the hospital way before this. So we generally say we'd like to give the hospital 30 minutes to do the procedure. Now, maybe we give them 15, 20 minutes. So we're shrinking this window on both ends. You gotta get them to the hospital, not at 60 minutes, you gotta get them to the hospital around 30, 35, fudge factor, that's parking outside the hospital, going inside, right? So your window, and then you get to the patient's bedside at maybe 12, 15 minutes. You've got to recognize that somebody is an ECMO candidate and hustle, because you've really got a total on-scene time, realistically, probably of 15 minutes or less in most cases.
Station 1 and 10 district, basically.
So that's so. Which hospitals in our system do ECMO?
UNM.
Well, in our,
Russ.
okay, UNM does, Press Downtown does. We're not ever going to get to them in time, ever, unless the patient codes on the way. So it's only Rust, and Rust is only offering it 7 to 7, 7A to 7P. That's important. So knowing all of these factors, you have to have, you're not going to, points, perfect. It's not going to happen in really anywhere, but within really maximum of a 10-minute drive to Rust. Again, case by case, traffic, time of day, all these things. So time is really critical. What else is it in? Well, okay, so age, less than 75. So the lower limit is a little unclear. We've just extended it down at UNM into the adolescent range, but the problem is that most of the patients that are in that age range aren't ECMO candidates for the other reasons that we're going to talk about. What else? Is every patient that's 75, otherwise healthy, that can get to the hospital in a timely manner an ECMO candidate?
No, but I can't remember why.
So, okay, rhythm is huge. Initial rhythm, your first rhythm determines everything. It's not the rhythm when they arrive at the hospital. It's your first rhythm. And it really needs to be shockable. We make a small exception for PEA with ultrasound activity. So PEA plus a medcom puts an ultrasound on and the heart's actually doing something. But most of the time we're talking about, so but in general, your PEA patient, first rhythm, not a candidate. Unless medcom just happens to be there in a timely enough manner and everything else is perfect. So shockable rhythm. So that's not most of the codes we see. All right, what else? Because one of the keys here is we can save the heart with ECMO very easily. But we got to be able to save the brain.
End tidal greater than 10.
Okay, so things that tell us that the patient may have had a more profound downtime, all right? So, or you could say it as an exclusion, low CO2s. Maybe I'll put it that way as a exclusion. So end-tidal CO2 that's really low initially, or at any point. So in general, if you go to transport and you're thinking, okay, I'm thinking that initially the CO2 was 20 and you're getting ready to package up to transport and the CO2 is now dropped to 8, we're done. There's another really important factor
Bystander CPR.
here. Yeah. So people word this a little bit different. Witnessed CPR. The ideal patient is one that has a witnessed arrest and bystander CPR. If it wasn't witnessed, but family feels like it was a downtime of it was super short and they're in VFib, take them anyway. If we can decide at the hospital. If it was witnessed but there was no CPR, that's no good. And sometimes we don't know. And the case example that I give, this just shows you how it won't be surprising to you, but we put a patient on pre-hospital last year out at the Amazon, the big Amazon delivery center there. And the call came in and everything seemed like witnessed cardiac arrest and the first rhythm was VFib and he stayed in VFib. And so seemed like witnessed arrest, bystander CPR, VFib, were like rock on. Got him on ECMO, he was brain dead. When we teased out later at the hospital, the circumstance was that they were in a semi, and it was the son was driving and dad was asleep in the back. And they were just low speed pulling in, they were kind of queued up to do their drop. There's a long queue of trucks there at the Amazon site. And no, I take it back. Dad was driving, son was asleep in the back. They hit the truck ahead of them at low speed because dad had collapsed. The dispatcher was smart enough to realize that this probably wasn't trauma, and told the son, "Hey, ask the right questions. Dad's, sounds like dad's in cardiac arrest. You need to start CPR." Well, so technically, son was in the truck when the incident happened, which is why it was considered witnessed. I mean, he was asleep in the back, dazed, whatever, and he did start CPR. But the detail was that dad was like 240 pounds, and he's a cardiac arrest patient in the driver's seat of a semi. By the time he got him out of the truck, called 911, recognized what was going on, got him on the ground to start CPR, it was probably at least 5 minutes that he had no CPR. Technically witnessed, technically bystander CPR. So you can imagine, there's a lot of detail in this that you just make the best decision you can at the time. You can't always know. But shockable rhythm that's witnessed in the right age without major comorbidities are the big factors, and you can get there in the right amount of time. But ECMO is good, or ECPR is good. ROSC is better. So what we can't do is get all focused on getting somebody to the hospital like we used to do scoop and run with the baby football, and we don't take care of all the things. If the patient's really going to have a good outcome, it's because of what you do. So you still have to start high quality CPR. You have to have a Lucas on. We're not transporting a patient who doesn't fit in a Lucas, or the Lucas isn't available at that moment, or the Lucas does, okay? We're not transporting people with unrestrained, trying to do CPR. No, we're not doing that. So, still gotta get the Lucas on. You still have to take care of the airway however you're gonna take care of it. And most importantly, you have to have pads on, and you have to do at least a couple shocks. And I'll take or leave access and epi, that's a whole separate discussion, but you still have to do those things. So you start thinking about how fast and efficient this has to happen. So we don't have that many patients that qualify here because of the number of cases we have that are VFib arrests that are witnessed to begin with in Rio Rancho, that are in the district, and we only have ECMO 12 hours a day. In Albuquerque, where you get more reps, because we have 2 hospitals that do it 24/7, and it's just a bigger population base, people start getting pretty damn good at recognizing this. One of the advantages is the alarm room in Albuquerque actually gives pre-alerts to the crews of a potential ECMO candidate. So on the way to a call, people are already sometimes saying, hey, possible ECMO. They've already figured out the age. They already know there's bystander CPR and it was witnessed. Now it may not turn out to be that way when you get on scene. And the dispatchers are pretty good about figuring out drug. Oh, I forgot the other big thing is out. This is huge. Respiratory causes. If you had a respiratory event, you're not a candidate. Now the good thing is most respiratory events don't lead to shockable rhythms. But if you have a strangulation or you have a drug overdose, you're out. Because your brain died before your heart did. So that really narrows down our pool. But if you're in the district and you know on your way to a call, yeah, I could, based on where this is, if everything lines up and it's daytime hours, I might be able to get the patient to rust in time. Then you have to go in trying to both simultaneously do all the right things for the patient and be figuring out if this patient is a candidate. Now, if it's just 2 people showing up on the scene initially, right, you're just gonna have to focus on, or 3, the call. But if it's a full response and people are there, it's nice to, if you can designate somebody in advance to be like, hey, we're gonna focus on the patient if you can figure out if they're an ECMO candidate. And they can just kind of run through that and figure it out. Like, yeah, hey everybody, this is a candidate. Then you put your, then from the get-go, you're thinking about it. Because that's one of the real rare times that we will transport somebody with CPR in progress. I'll also add, you have to give the hospital a lot of advance warning. Because at Rust, the doctor who is doing this procedure is the ICU doc. So if he or she is busy doing a central line in the ICU, they need warning. They need more than 3 minutes warning to get down to the ER. So we'll often, in Albuquerque, we'll often have people calling from the scene before they even leave. The 7-8, that's our Medcom equivalent at AFR, will often make a heads-up phone call when people are still packaging on scene, just so the hospital can get 15 minutes of heads up. So we're all ready. There were hands, yeah.
I know it technically would be probably respiratory out, but I had this happen about a year and a half ago for a PE, classic sign of PE. Respiratory, like she wasn't able, shortness of breath, acute onset, pinpoint chest pain, has had cramps over the past few days. We get her in the back of the ambulance. We get pads on her, and then she just coded on us. She went in VTAC. We shocked her right away. We got ROSC, and that. Considering that, would you say we could do like a V to V ECMO?
So see, the problem here is time is short, and I could talk about ECMO all day. And interestingly, we don't generally use VV ECMO for PE, but so PE is actually a great candidate for ECMO, especially if we can get to the patient before they come. So massive PE. They used to die all the time. Our mortality rate at UNM for massive PE 5 to 10 years ago, the mortality rate was 80%, and now our survival is 80% based on adding ECMO. But the key to it is getting to the patient before they code. If they code from a PE, they are a potential candidate still, but they would be. We don't consider that like a respiratory cause, which is different. Respiratory cause means you stopped breathing, not you complained of shortness of breath. Your breathing stopped before your heart, right? You fentanyl overdose, hanging, you slowly grade down as you get more and more hypoxic, but your brain dies from the hypoxia before your heart does. So PE, that candidate, especially with the shockable rhythm, is definitely still a candidate. The fact that they coded in the back of your truck makes them an extra good candidate. The problem with massive PE is that if it is that big a PE, and we don't always know, but if you think about PE, and this is fascinating, my art isn't that good, so you're just gonna have to use your imagination, right? You think about a pulmonary embolus, if you think about blood flow, comes into the heart on the right side, goes through the lungs and comes out to the left side. Pretty basic. If that clot that's sitting between the right and the left side is so massive that it is completely blocking blood flow, then your CPR is doing nothing. And I put somebody on ECMO a few years ago, another one of our pre-hospital cases, young person in their 30s, collapsed, bystander CPR, rhythm was PEA, the 7/8 Medcom equivalent had a good ultrasound activity, clearly like, we have to put this patient on. When we got to the hospital and we did a CAT scan, and we inject CAT scan contrast on the venous side, and so that contrast goes into the vessel, goes to the right side of the heart first, then it's supposed to go through the lungs, and it's supposed to come out on the left side. It was such a complete clot that there was zero contrast going from right to left, which meant that the CPR that we were doing for that whole 30 minutes was worthless. We didn't know it at the time, right? There's no way to know, so we gave the patient the benefit of the doubt, but can't get blood flow across. So that's why we like to get to them early. So if you do happen to have a patient that you have a suspicion, your gut says this is a PE and a big PE. They got a little pleuritic chest pain, but no, they've got pleuritic chest pain and they're hypotensive and hypoxic, really should try to get that patient to an ECMO center. So even though they look kind of crappy and you're like, I don't know if this patient's going to make it, taking that patient to SRMC, nothing we can do for that patient if they code. I mean, we can give them TPA or whatever, but they really need to be in an ECMO center. So this was a long digression from the point of when do we ever transport a patient with active CPR? We transport a patient with active CPR when we think we can meet those criteria, which is almost never kids, right? Because kids don't tend to have shockable rhythm cardiac arrests. Kids almost always code from respiratory causes, which is unfortunately why kids are rarely candidates for this. We did have a case at UNM not that long ago, which made us rethink things because we had a teenager that coded from cardiac med overdose. And so basically went into a dysrhythmia from having overdosed on cardiac meds, not because they overdosed on opiates and stopped breathing. That patient was actually a candidate and walked out of the hospital neuro intact. But that was, and she was, so that's one of those rare events. The other time that we would transport is hypothermia. The hypothermic patients can last an unbelievably long time if they're truly hypothermic. So they're hypothermic, we have ECMO available now, just transport unless they're frozen solid. And then trauma, just the last thing we wanted to kind of circle back, trauma arrest, is just basically pull up your trauma arrest guideline, treatment guideline, just to review a few things. It is, we've had a few trauma arrest cases lately. People have done good jobs with them, but just remember that a blunt trauma arrest, so it's a day of categorization, right? We spent the day categorizing things. So yet another way to categorize arrest is medical arrest, trauma arrest. Within trauma, blunt trauma, penetrating trauma. Blunt trauma, you fall off the roof. Blunt trauma, motor vehicle collision. Blunt trauma, you get hit in the head with a baseball bat. blunt trauma. Penetrating trauma, right? Shooting or stabbing. And we're not talking to the head. Okay? If you get shot in the head and you're in cardiac arrest, that's, it's its own entity. But one thing we can say is that blunt trauma arrest is not survivable. If you roll up on scene at any level of training for a blunt trauma arrest, you're going to confirm that it really is a blunt trauma arrest. Because the worst thing to miss, and I missed one of these a few years ago, is a patient who had a medical event that led to trauma. And it really wasn't a blunt trauma arrest. So, pretty major damage to it, like major damage to a vehicle. And and it was a VFib arrest, and I should have worked it as a VFib arrest, and I made the determination not to, and I got the OMI follow-up later, and there was no trauma to that person's insides. Not to say they would have survived it, but if I'd gotten a little better history and talked to some bystanders, eventually somebody did say, oh no, I just saw the guy unconscious before he hit the tree. So, you want to make sure it really seems like a blunt trauma arrest. And then start your basic stuff. Just make sure you open an airway, do very basic things, like do you open the airway and they stop breathing again? Probably not, but it's happened. So open the airway. You can assist some breathing while you're just trying to figure out what the hell is going on. If you're at an ALS level, it's totally appropriate, if you think there was trauma to the chest area, to put a needle in both sides. The chances that by the time they've arrested that's going to bring them back, even if it was a tension pneumothorax, is pretty unlikely, but you're not going to make them any worse. But on the other hand, if you're at the BLS, ILS level, I don't want you thinking, oh my God, I just have to do CPR and keep this person going for 10 minutes until ALS gets there to stick a needle in the chest. It's just not going to fix the problem that dramatically. Right? If you have ALS around the corner, 2 minutes away, totally reasonable to wait for ALS just so you feel better about the decision making. You're really not having ALS come for the needle in the chest. You're having ALS come so you have somebody with some more experience potentially to make a decision together that this is really, because that's a hard decision to make, to say we're not doing anything. Because a lot of trauma arrests are young, otherwise healthy people, and that sucks. But CPR does not fix anything in a trauma arrest. In a medical arrest, it might keep them perfused well enough to get to the hospital for ECMO. We don't do ECMO for trauma at this point. And if you coded, think of the things that you code from in trauma arrest, from blunt trauma arrest. You code because you emptied your blood volume somewhere in your body. CPR on an empty heart doesn't do anything. Okay? You coded because you have an obstruction in your system, pericardial tamponade, for example. CPR is not going to fix that at all. So, it's not a CPR situation. It's a confirm that this is really a blunt trauma arrest. Open an airway and make sure there's nothing simple to fix there. And if you can do it in a timely manner, needles in the chest. And then we're done. Adult, pediatric, we're done. It sucks. It's just certain things we can't fix. These are guidelines. If there's a trauma arrest in front of Rust Hospital, and you want to transport that patient into Rust Hospital because you feel like the optics of stopping when there is a hospital within sight, even though it's totally justifiable, I get it, and we all get it, right? And if the hospital has an issue with that, we can talk to them about it, but they probably won't, right? But we're not going to do CPR that's completely ineffective and race somebody across the city to a hospital, or we're not going to go downtown. So blunt trauma, it's just a shitty situation, but there's certain things we can't fix. Penetrating trauma, to the head, if it's truly a cardiac arrest from that, right, that's, you know, that's not generally a fixable situation. Blunt trauma to the chest, the torso, the box, as people will say, has a slight survivability if everything lines up. So that's the one case for a trauma. The other case, besides medical arrest, ECMO candidate, hypothermia, and penetrating trauma arrest, that you, to the box, that you think might be fixable because you can get them to the hospital in a very quick manner based on where you're at, especially you can get them to SRMC. So that's the one time you might consider it. And especially stab wounds, we have a much better chance, you can imagine, with a stab wound than a gunshot wound. We're not going to race that patient who's in trauma arrest 10, 15 minutes across the city, because the CPR, if they're in trauma arrest, isn't going to fix anything. It's the same thing, right? Trauma arrest, blunt arrest, CPR doesn't fix anything. So we've generally stopped doing CPR for trauma arrest in the city. I actually got a QA recently from the trauma service asking me why a flight team was doing CPR down from the roof. Because they're like, CPR doesn't do anything in trauma arrest. I'm like, oh my God, I spent 10 years trying to convince you guys of that. And now they're like, oh yeah, so it doesn't do anything. So all that time that you're transporting that patient, they're not getting their brain perfused. So it has to be here where we think we might have a chance of fixing something quickly, and the time is short enough that we feel like even if we're not getting good perfusion. I'm not saying you're not going to do it, right? I mean, you're not going to, you know, kind of feel stupid sitting there, just sitting there like in the back, not doing anything. But I also don't want anybody to get hurt. To save for a chance that it's like 0% survivability or close to it. So what I don't want is things to happen too fast and then something bad happens to somebody. So that's super important. Questions? We've covered a lot of ground.
There.
Yeah.
Is blunt trauma to the head with an arrest, is chest already been indicated at that point?
No, not that's going to hurt anything, but it's not indicated yet. I mean, if you're not now, the issue is sometimes people would say, well, you know, well, they fell off the roof and it looked like massive head trauma, but how do I know there wasn't chest trauma? Fine, throw it, you know, if you want to put needles in, it's totally appropriate. If, on the other hand, it's truly baseball bat to the head, yeah, no, I'm not going to bother. Okay. Guess you guys get a long lunch. What time are they back?
12:50.